Hello everybody and welcome to the Thursday edition of Video Clips. I want to talk about cancer statistics, which can, as it turns out, be quite deceiving. Now, why this is important is we spend billions of dollars every year in this country trying to develop new cancer treatments. And there are financial incentives. Obviously, drug companies and oncologists make a lot of money on this stuff. But how the money flows into research somewhat depends upon the cancer industry, let's just call it that for now, reporting that things are getting better, that they're succeeding. So improved survival equals more funding for cancer research. Now, where does all the funding come from? Well, the National Institutes of Health is one source, and then a lot of the nonprofits get involved in this, like the American Cancer Society and the Susan Komen Foundation. They raise tens of millions of dollars, and some of that is allocated for cancer research every year. Survivors are expected to participate in this stuff, wear pink ribbons, raise, testify in front of Congress, be featured in advertisements, and all of this is justified to keep the money coming because we're told survival rates are improving. But what if they're not? What if selective reporting makes people think that survival rates are better when they really aren't? So mortality rates are determined by taking the number of people who die of a disease in a year and dividing it by the total number of people in the population. Survival rates are the number of people who live for a certain amount of time after diagnosis, and of course in the cancer business, 5 years beyond diagnosis is considered the benchmark that you're looking for. But mortality and survival are quite different animals, and almost all reports that discuss outcomes for cancer treatments use survival statistics. But survival statistics can be a little misleading. Dr. Aaron Carroll, a professor at Indiana University Medical School, recently wrote about this in a New York Times op-ed piece in which he discussed the two main issues that contribute to misunderstandings about just how successful today's tests and treatments for cancer really are. One issue is lead time bias, and I'll explain what that is in a minute, but it's become a major problem since we're diagnosing more cancers at earlier and early stages. Now, we've been all told that this is really a good thing, but it may not change your life expectancy at all. And remember, the goal of testing and treatment should be that you live longer, not just that we're going through this exercise to churn a lot of money through the reimbursement system. Dr. Carroll provides a great example, and I like this. I'm going to use it. He says, let's take the hypothetical disease of thumb cancer. Assume that there's no way to detect thumb cancer, as in your thumb, until you feel a lump, and that there is no effective treatment for it, and that everyone lives for about 4 years after diagnosis, even if you have some treatment that doesn't eventually work, and that happens all the time in the cancer industry, unfortunately. The 5-year survival rate is 0. Everybody dies before 5 years. But then a company comes along and they develop some new technology that detects thumb cancer 5 years before the lump would actually be found. But the treatments haven't changed. So now everybody's dying 9 years after diagnosis instead of 4, and the 5-year survival rate has gone to 100%. But nothing has changed. The same number of people are dying of thumb cancer. They just find out about it earlier. They live with it longer. They receive the same treatment that doesn't work for them any better than it worked for the people who waited until they felt a lump. Now, who wins in this situation? Manufacturers of the testing device, the doctors, drug makers, hospitals. Everybody's making money at this, but patients don't fare so well. They suffer the side effects of treatment. Healthcare bills are inflated. No difference in the outcome. Everybody dies of thumb cancer. This is the situation with screening tests and treatments for most types of cancer. More screening is done in the United States than almost any other country, and the medical community justifies that by reporting that the survival rates have improved. Statistically, as I just showed you, that might be true, but for the patients who undergo testing and treatment, nothing has changed. Their chance of survival hasn't changed at all. Now, the second issue is overdiagnosis, and this is even more serious. Again, let's use the hypothetical disease of thumb cancer. And let's assume that using this testing, this very sophisticated testing device that somebody has developed or some company has developed, that we're getting this diagnosis earlier and earlier. But almost certainly some of those people who are diagnosed early would never get thumb cancer. All right. So with those people, however, they still get treatment. And treatment for diseases you don't have is always overtreatment. There's always a downside to it, and there is no upside. You didn't have the disease in the first place. Then these people go into the survival category, making the numbers look even better, which gets the money flowing into research even more to perpetuate this insanity. Now, this is the case with many cancers, particularly breast and prostate cancer. There are lots of articles in the Health Briefs library about this. I'm not going to regurgitate all of it here. But in the case of breast cancer, widespread use of mammography has not lowered the mortality rate. The reason is that we have lots more diagnoses, but many of those cases are ductal carcinoma in situ, which really, most of the time, doesn't develop into cancer. In other words, these women have clinical abnormalities, but not cancer. They'd all be alive 5 years later, whether they got any treatment or not. But they're labeled as cancer patients. They're given treatment for their pseudo-disease. It's not really disease. And then they go into this, the survivor category. This is always over-treatment. Meantime, in the meantime, the treatments and survival rates for women with aggressive cancers and metastasized cancer really hasn't changed at all. For prostate cancer, the situation is even worse. According to Dr. Richard Ablin, the researcher who discovered prostate-specific antigen, PSA is not a reliable marker for prostate cancer. The false positive rate is 78%. The biopsies are not any more reliable. Most of the men who've been diagnosed, air quotes around that, and treated, air quotes around that, for prostate cancer, probably didn't have it. They also had clinical abnormalities that would be best ignored. But the number of diagnoses of prostate cancer has increased. The survival rate has increased, while the mortality rate from prostate cancer has not changed at all. The lives of millions of men have been negatively affected. They almost all suffer from incontinence and impotence after treatment that doesn't benefit them. Now, during the last several months, I've been delivering a lot of presentations about the importance of informed medical decision-making. I explain what this means, knowing the risks and benefits of any test, drug, supplement, or procedure before consenting to it. And then I ask, how many people have had a discussion like this with a healthcare professional? So far, nobody has reported having a discussion with anybody outside of this organization that meets that criteria. Now, this has to change because every day people in this country are subject to overdiagnosis and overtreatment, and cancer isn't the only disease for which this is common. It just happens to be a little bit more egregious because the diagnosis of cancer is so terrifying to most people, and people will consent to almost any test and any treatment to avoid death. The problem is the tests and treatments are often not successful. It's time for people to learn that they really should be a little bit more afraid of doctors, tests, and treatments than death from disease, and to get the information needed to direct their medical care instead of being directed to participate in medical care. Two very different scenarios. All right. Last thing for the week. Exercise cannot overcome a healthy diet. I've been writing about this for a long time too. I'm an advocate of exercise. I'm diligent about it, and I encourage, well, some people might call it nag, people to engage in exercise. But I've always said that exercise is not a substitute for eating well, and by itself it will not result in optimal health. And if you want some evidence of that, I mean, elite runners, Olympic athletes have heart attacks. You can't exercise away all that plaque and the damage that is done to your body from eating a bad diet. Well, a new article in the British Journal of Sports Medicine confirms this, stating, quote, "Let us bust the myth of physical inactivity and obesity. You cannot outrun a bad diet." That's exactly what they wrote. Health professionals and public officials are correct in being concerned about how sedentary people have become. In most westernized countries, exercise hasn't improved or increased at all during the last 30 years. However, and this is another direct quote from the article, the obesity epidemic represents only the tip of a much larger iceberg of the adverse health consequences of poor diet. The authors went on to state that poor diet contributes more to disease than a combination of inactivity, alcohol, and smoking, and that 40% of people with normal body weight develop metabolic abnormalities that we always associate with only overweight people, such as hypertension, dyslipidemia, non-alcoholic fatty liver disease, and cardiovascular disease. The researchers say that the food industry promotes exercise as a means for addressing the health issues that their products create. For example, companies like Coca-Cola associate their products with sports by getting celebrity athletes to endorse them and giving everybody the impression that it's okay to have all these things as long as you move around. The researchers also state that the type of calorie matters, pointing out that sugar promotes fat storage and hunger, and studies have shown that for every 150 calories consumed from sugar, there's an 11-fold increase in the prevalence of type 2 diabetes, independent of weight or physical activity levels when compared to calories from other sources. I agree with these authors and add that many popular foods are so calorie dense and the portions are so huge that there aren't enough hours in the day for people to exercise away the damage. You know, some children's fast food meals contain close to 1,000 calories, most of which is from fat. A kid would have to spend 6 to 8 hours a day on a treadmill just to overcome a couple of these meals. That's not practical. So here's my take on it. Exercise is important. Diet is important. Sleep is important. Happiness and stress levels are important. Relaxation is important. I mean, the path to health is comprehensive. There just aren't any magical solutions. And again, exercise is important. I do it almost every day. But I don't fool myself into thinking that that's my free pass to go eat French fries and oil and, cookies and garbage. It's not. It's just one component of a comprehensive plan for health. All right, that's all for today. As usual, pass this on to anybody who you think might enjoy watching it, and I'll be back to you next week with more news.